touch on Audit and PDSA, look at other resources that might help quality improvement, and then what you might want to do to share your quality improvement project or findings, and whether you might want to write it all up and get your quality improvement published in a medical journal or as a poster at a meeting or whatever. So we've got a lot to get through. If you have any questions as we go, please put them in the chat box, and hopefully we'll have time for questions at the end as well. And I'm going to try and make this an interactive session. So I'm going to pause every few minutes and ask you questions, and please do pop your answers into the chat box, or if you have further questions, please do pop them in. So the first section, what is quality? Well, most people would agree that quality improvement involves delivering care that is safe, effective, efficient, at the right time, that's patient-centered, and that is equitable. That's the definition from the Institute of Medicine, so it's a good source. But what does that mean in practice? Well, likely what it means in practice is that by safe, don't inject the wrong drug. By most effective, prescribe the best drug for the condition or give the best treatment for the condition. Most efficient, that's affordable, that's lowest cost. NICE is the National Institute of Clinical Excellence in the UK, but it's all about effectiveness and also cost effectiveness. At the right time, so obviously if you can have an earlier diagnosis, so much the better. That's patient-centered. That's in a way that the patient will appreciate, that the patient wants, that addresses issues that matter, that are important to patient. So patient might want to be at home, might want to have nurse-led care, and that's equitable. So by postcode lottery, it's a UK term, but what we mean is that everybody receives the same level of care. Everybody receives excellent care, whether no matter what part of the UK you live in. And that's, of course, what we want to see in India as well. And so, in sum, what really we're talking about is good healthcare. That's what we want to achieve that's what we mean by quality. And if that is quality, then what is quality improvement? Well, here's a definition from the journal Quality and Safety in Healthcare, now called BMJ Quality BMJ Quality and Safety from 2007. And Battledon and Davidoff define quality improvement as the combined and unceasing efforts of everyone to make the changes that will lead to better patient outcomes, better system performance, and better professional development. So the important things about that, it's unceasing, it never stops. The ultimate goal we're trying to achieve is better patient outcomes, and I'll address that some more in a minute. And it's difficult to get to that. We might use a surrogate of patient processes in the meantime. I'll also be talking briefly about systems of care and professional development. But achieving this, all of this means one thing, which is change. And change isn't easy. And the first thing when you're trying to make change in your institution is to make the case for change. So people will ask you, well, why do we need to do this? Why do we need to change the way we do things? Surely we can leave things the way they are. So you need to make the case for change. So the first question you might ask is why now? And this is a chart that shows national statistics on total infant mortality in England and Wales between 1900 and 1999. And you can see it's a really good story. And that you can see from 1900 to 2000, the infant mortality has fallen rapidly. But you can look at various stages. In 1911, they might have thought, actually, infant mortality is much better. Maybe we can stop doing quality improvement. but wouldn't that have been a mistake if they had done that? Because there was still a lot of room for improvement. And at the same time, as things like that have improved, other things are a cause for concern. So here's medical error reports reported in England and Wales between 1939 and 1998. And as you can see, those have risen at the same time as mortality has fallen. And there are multiple examples of errors involving near misses, sometimes, or critical incidents involving all members of the team, doctors, nurses, managers involved, sometimes system-wide problems in care. And it's important sometimes to mention these because these are really important in making the case for change if there is medical error. And you might ask, what are we talking about? Do we want everybody to improve? Or is it about raising the ceiling? Is quality improvement about raising the ceiling? Is it about looking at groups that are really achieving excellent care and kind of driving them even more to go the last mile in improving healthcare? Or is it looking at things that are really going wrong and saying we need to raise the floor through patient safety so that the bottom 10% improve? And the truth is, it's about both. We need to both raise the floor and raise the ceiling so that everybody improves. And that's something that BMJ believes in, that quality improvement must be unceasing, and that there's always room for improvement in all systems, including indeed the way BMJ does things as well. So we also believe in this idea of all teach, all learn. So I'm an educator by background, worked at BMJ for a good number of years. I started at BMJ around 15 or 16 years ago, and I started 6 weeks before we launched our first e-learning website, BMJ Learning. And it was an exciting time back then. And of course, we've been trying to educate doctors and other healthcare professionals, but we've learned a massive amount ourselves in delivering that education. And we've learned it from our users, from our learners. So how big is the problem that we might want to address? So hospital care, 1 in 10 hospital patients are at risk of harm at some stage during their hospital stay. It's a remarkable statistic. In primary care, 1 in 100 patients are harmed. But in primary care, there's so many consultations across primary care. In the UK, probably over 300 million consultations per year. And so what it means is that even if it's only 1 in 100, you're talking about millions of episodes of harm. So it's a massive gap and a massive room for improvement. And how can we improve? Well, we can use knowledge, research and guidelines and systematic reviews and papers, which we can put into practice to drive quality improvement. But the one issue with that is information overload and knowledge overload. How can we possibly keep up with so many randomized controlled trials per year? The amount of medical information doubles every 5 years. COVID-19 is a good example of that, where there are now thousands and thousands of articles about COVID-19 on PubMed. Already 11 months ago, there were none. And despite this tide of information, on average, it takes 17 years for clinical research to become routine clinical practice. It's remarkably slow. So one example is thrombolysis and myocardial infarction, where the trials demonstrated the effectiveness of thrombolysis in myocardial infarction in the late 1960s and early 1970s. And yet, it was the 1980s before it was routine clinical practice in all hospitals, including district general hospitals in the UK. And that's an example of quality improvement. What about patient safety? Well, unfortunately, in the UK and around the world, there have been critical incidents and patient safety incidents when patients have been injected with potassium, intravenous potassium, instead of saline. And despite that occurring, it occurred again and again. And despite the fact that there were guidelines produced, it still happened. So it can take a long time for knowledge to get into clinical practice. And yet that's something that we absolutely have to do. So there are multiple cases for change. And I said I wanted to try and make this interactive. So I'm going to ask you a question, and I want you to put into the Q&A. I want you to say, what's the most compelling case for change where you work? What do you think you most need to improve where you work? What's the reason where you work where you think we definitely need to do a quality improvement project there? So I'm just going to, if you want to put questions into the chat box, if you can, or I don't know, just wonder how best to do this. I'll just stop sharing for a second. Oh, great, excellent. People are putting them in. So I'm just going to give you a few seconds. So lots of good ideas there, from medical errors, medication errors, through to birth asphyxia, through to work efficiency, through to sepsis and neonatal sepsis, OVR. I'm not too sure what OVR is. Somebody can spell it out for me. At BMJ, when you're writing a paper for BMJ, never put any abbreviations in. Spell everything out. Just assume that the editor won't understand. So anyways, lots of really good ideas. Thank you. I'm just going to go back to sharing my screen and some questions about techniques for quality improvement, which we'll address also. So we're going to move on to some themes for learning about quality improvement. And the first one is systems thinking. So this is the world's largest rugby scrum in Ireland, with 1,700 people in a rugby scrum. Rugby is a team sport, and nurses and doctors and other healthcare professionals, pharmacists and therapists need to see their work as part of a larger system at a team level, a department level, institution, hospital level, or whatever. And I'll return to this and give some examples in a second. We also need to get better at measuring performance, and at a national level, at a team level, at an institutional level. And we need to get better at data. We also need to think about adapting and and slowly improving and making incremental gains. And the theory of incremental gains is something that's really people are thinking a lot about in the UK and in Europe and elsewhere. It's all about change coming from within an institution rather than somebody coming into an institution to try and change things or adopting a new system. You're much better to usually to change your existing system, because in changing that, you'll hopefully change your culture as well. A famous quote from Peter Drucker is that culture eats strategy for breakfast. You need to change the culture if you're going to introduce change in a system. And incremental gains, people often use the analogy, a sporting analogy, another sporting analogy from with the British Olympic team used, particularly the cycling team, whereby they made small changes and they measured it, like their saddles. And then they made some more changes, like in their diet, and they found that it might cut 1 second of their time. And then they made another change and it cut another second of their time. But after all these changes over a period of months, they found that they were cutting 10, 20 seconds off their time, which they didn't think would be achievable, but it was through slow and incremental adaptation and improvement. Now, there's a skill set and a knowledge base to quality improvement. And there's various tools and approaches that you can use, and a lot of them are rigorous ones. But the evidence suggests that improvement is agnostic to the method or approach taken. So you could use the model for improvement or PDA cycles or whatever, but you need to have an approach. It's critical to have a method and a methodology and a theory underlying what you're doing. And we need to get used to working with complexity and understanding that we're working in healthcare, which is a complex and adaptive system. And changing one part on its own will rarely have a massive effect, and sometimes will have unwanted effects that you didn't foresee. So take an example from nursing and pressure ulcers. You know, I'm a geriatrician by trade and a doctor, and I used to work in the Royal London Hospital in London, in the East End, for a professor there who was very enthusiastic and very interested in pressure ulcers. And he used to always say pressure ulcers are the duty of the doctor as well as the nurse to prevent pressure ulcers, which is quite right. But you might say, okay, I'm going to introduce a new method of preventing pressure ulcers, and we're going to have new mattresses on our wards, and people at high risk of pressure ulcers are going to use those mattresses. But just doing that on its own won't be enough. You'll need to have porters who'll be able to bring the mattresses in. You need to have different types of beds so that the mattresses will fit onto. You need to have different types of wards to have those mattresses on. Your nurses and doctors and allied healthcare professionals will need to be trained in risk assessment. So they'll need to know what type of patients go on what types of mattresses. You'll need to involve finance so that because some of these mattresses will be expensive. And I could go on, but we need to think that we're working in complex adaptive systems. And yet how we produce guidelines in medicine often assumes that we weren't. We might say, okay, you need to give this treatment without thinking about all the various supply chain management issues that might be involved in delivering that treatment to the patient. And implementation matters. It really does. So here's an example of a stroke reconfiguration strategy to drive quality improvement for patients with stroke. And it was implemented in units, in 2 units, one in Manchester and one in London. But they implemented in very different ways. And you can see that the results that they got in London in the red line, dotted line, and in Manchester were very, very different. And London ultimately did much better. Why? Because London's implementation strategy was simpler, so people could understand it. Everybody could understand it, because stroke care is a multidisciplinary team game. It was also inclusive, so their strategy involved doctors, but also nurses and nurse specialists and pharmacists and everybody who's involved in stroke care, like therapists, occupational therapists, like physiotherapists, occupational therapists, social workers, etc. And it was also much more hands-on. They involved the team in the implementation. And they also had different financial and clinical incentives to get it going. So how you might implement your quality improvement project really makes a big, big difference. I should have said at the start that these are not my slides. These are slides from BMJ, but I've adapted them to my needs. But if anybody wants these slides, you're very, very welcome to have them. I will share them with Dr. Vikram or anybody else who can then share them with all of you. But I'll put my email address at the very end. And if anybody wants to email me, then they're very, very welcome to have these slides. So quality improvement and audit, what do they have in common and what is the difference between them? Well, quality improvement and audit, of course, are really, really quite different. And quality improvement is about having a brief planning change and then doing change and small tests of change and then repeating the quality improvement cycle rapidly. Now, audit is different, and it's not to say that audit is bad and quality improvement is good. It's rather to say that audit is a different purpose. An audit can be good at a national level, but often at a local or team-based level, often it doesn't bring about the change that we would have hoped. So that's why I'm deliberately talking about quality improvement. Now, quality improvement is all about doing things. And so I hope that you're finding this talk helpful. And we're a bit less than halfway through. But for this talk to be a success, what I want you to all do is to think about how you can start up a quality improvement at your institution locally, how you might lead it yourself, or how you might get involved in quality improvement. So on Monday, I hope to see you all go down to the quality improvement department and come up with ideas. And so another question I want to put it to you. If you could do one quality improvement in your institution next year, what would it be? So please, come on, let's put your answers into the Q&A or the chat box again. If you could do one quality improvement in your institution next year, what would it be? So I'm just going to stop sharing for a second again so I can see. So lots of interesting ideas. I want to do a quality improvement on newborn resuscitation, on neonatal sepsis reduction, on improving discharge processes. So discharge processes is a really important one. And if you want to talk about a complex system, then discharge is absolutely all improvement, is all about system-wide improvement. Early initiation of breastfeeding in C-section delivered babies. So it's an important one as well. Okay, so many ideas. Fantastic. Excellent. Thank you. Somebody, I hope, can make a record of all these and share it. Thank you. I'll go back to my presentation now. So there's different methodologies for quality improvement. One important one is the model for improvement, or PDSA, plan, do, study, act cycles. And a mistake that's sometimes made in quality improvement is you dive in and you start without asking these questions at the very start of your project. What are we trying to achieve? How will we know that a change is an improvement? And what change can we ultimately make that will result in improvement? And it's critical to ask these initial questions first and to spend some little bit of time on them. Too often they're missed or they're rushed through. And it's also important that you have a vision of what you're trying to achieve, a simple and straightforward vision that everybody in your institution will understand, from the professors to the porters, but also that you have aims, and aims that are smart, specific, measurable, agreed upon, realistic, and time-based, so that you can say, we want 90% of people with HIV to know their HIV status by the end of 2020. And one thing I like about the 90-90-90 target is that, once again, it's very simple and easy to understand. It is specific, it's measurable, it's time limited and time based, and easily agreed upon. With everybody will agree upon this, that this is worthwhile doing. But also, it's got a bit of vision to it as well. It's easy to remember. Everybody, after this talk, you might forget everything else, but I bet you'll remember 90-90-90. How can you not remember that? So we'll come back to thinking about good titles for your quality improvement initiative in a minute, but I'll come back to that as well. Another example is that NHS Improvement in Wales started to on a project called 1,000 Lives Saved. Now, who is going to forget 1,000 lives saved? People, when they come into work, they'll remember they're coming in and they're part of the project, 1,000 lives saved. So it's worth remembering things like that. Then you move on from planning to doing, the PDA cycle. And here, once again, it's about measurement, doing, and measuring what you're doing. And what you want to do, if, say, returning to improving a patient with stroke, you want to aim for them not just to get better, but maybe to shorten their walking time to where they can walk 20 yards to 1 minute, or something like that, or shorten waiting times for an outpatient apartment to less than 1 month. And it's also important to study what you're doing, PDSA, S standing for study. And here it's really most often a balancing act between process measures and outcome measures. And so, to return to our stroke patient, ultimately what we're trying to achieve is good outcomes for that patient, whereby they'll survive their stroke and they'll be able to be discharged home to their own home, where they'll have good quality of life and good functional capacity, and they'll be able to look after themselves. That's the outcome we're trying to achieve. But there are multiple processes that will help us achieve that outcome, and sometimes that will act as surrogates for that outcome. So you might say, okay, we're going to get everybody get them an aspirin within 4 hours of their onset of stroke, or we're going to get them to a unit where they can be thrombolyzed within 4 hours or 2 hours of their onset of stroke. And that's a process type outcomes. And stroke, once again, it's difficult to achieve that, because the example of thrombolysis, well, you need a CT scan. You need a unit where there's a CT scan, and you need a CT scan 24 hours a day, on call and at the weekend. And you need to have somebody who can read the CT scan, and you need to have thrombolysis available, and pharmacists on call, and nurses who are trained to deliver it, etc., etc., etc. So it's very much all about kind of systems thinking if we're to achieve these processes and ultimately the outcomes. Now, it's important it's impossible to mention the study, the measurement, without talking about run charts, where we might want to plot data over time and integrate data measurements into our daily routine. And if we can do that, that's really half the battle. You don't want measurement to be an extra thing that people have to do. If you can integrate it into daily routine, it'll be much more sustainable and achievable, and will become embedded, and it will be sustainable. So even after the end of your quality improvement, people will still be thinking about measuring and improving. So that's just a couple of things about run charts and how to read a run chart. And they're small but really important. So ultimately what you want to achieve is a shift in the process. How do you know you've got a shift? Well, it's indicated by 6 or more consecutive points above or below the mean. That's what you're trying to do. How do you know that you've got a trend? Well, a trend is indicated by 5 or more consecutive points increasing or decreasing. And that's important as well, because obviously there is random variation in measurements, but what you want to achieve is a shift or a trend that's sustainable. Now you might, and now if you see sometimes too many or too few runs, that can indicate a non-random pattern. And if you see what's known as an astronomical data point, it's often a pretty good signal, once again, of a non-random pattern. So these are useful tools for interpreting run charts. So I've mentioned a few simple things about PDSA and run charts, and the fishbone diagram being another example. But I want to pause and stop and ask another question. Does everyone in your institution know what a PDA cycle is, or what a run chart is? Would you say that all the nurses in your institution, senior and junior, know what it is, know how it's used? So once again, please, sorry, click on that. Please do. Thank you. Thanks for taking part. It really is excellent. Thank you. I'm going to stop now. Thank you. And I'll go back to sharing my screen. And we'll go back to the presentation. So that was very helpful, and not quite a straw poll, but nearly. But there were, I think it's fair to say, there were more no's than yeses. and quite a few people said a small number would, or not many would. And that, well, two things. First of all, to achieve quality improvement, everybody in the institution needs to know about these things, because if you just have one person championing it, that person will get tired and will not be able to sustain it over time. You need to have everybody thinking about it. And because it's a system-wide approach, a team-based approach involving complex adaptive systems, this means, once again, everybody needs to be moving in the same direction. And it is achievable. So 10 years ago, I started talking about quality improvement. And I remember asking some junior doctors and nurses in England about quality improvement. And I asked them, what's a PDA cycle? You tell me. And a lot of them looked at me blankly. They didn't really know what I was talking about. And a couple of years ago, I asked them again, a different group, but similar, junior doctors and junior nurses, what's a PDA cycle? And they all knew what it was. Now, it took time to achieve that, maybe about 5 or 6 years, but it's transformed in the UK, so it can happen. And what really made the difference, I think what really made the difference is curriculum. So now it's part of their curriculum in undergraduate and postgraduate training amongst doctors and nurses. And if you want to change things, put things in the curriculum and assess doctors and nurses on it, make it part of their assessment, so you cannot progress to the next year of your training as an undergraduate or postgraduate until you've been involved in the quality improvement cycle. So medical students, when I talk to them, they'll often ask me, will this come up in the exam? And I often laugh when I say I don't set the exam, but of course they'll ask you that question. And then we as doctors and nurses, we get frustrated and we say, oh, they're only interested in passing the exam. But you know who sets the exam? We set the exam. So why don't we set the exam, set the assessment, and say, to qualify as a doctor or as a nurse, you have to be involved in quality improvement. You have to know what PDA cycle is, what a run chart is. It's not difficult. It's not easy to find out and to learn about these things. But I promise you, if you do that, then the next time I come back to you and I ask you this question, I'll get all yeses. So anyways, there's lots of resources that you can use and that you can learn from. And here's just some of them. So we have a resource called BMJ Learning, and we're planning to put a package of learning modules on quality improvement up on that resource. And they'll cover these things, everything from foundations of change and change management through to leadership. Of course, you can't have quality improvement without leadership, through to systems and systems of care and lots of the things that we've been talking about, through to project management, stakeholder relations involving all members of the team, including doctors, nurses, and of course, patients and carers, vital stakeholders in the team, about how to design an intervention. We're going to have a module on the model for improvement, PDSA, etc., etc. So I know I'm racing through this, but this will be available soon, and we'll share a link to it if anybody wants to find out more. And this is BMJ resource, but of course there's a wide range of resources out there about these issues and about how to do quality improvement. So please do go out there, find them, use them. But then ultimately, you're going to have completed your quality improvement project, and you might want to share it. And we really encourage that. And you might want to go to an event and share interim findings. And so we run a range of events at BMJ. One important one is the International Forum on Quality and Safety in Healthcare. It's been going for about 25 years now. Started off in a major European city every year. We've also brought it to Hong Kong, Australia, Singapore. We're going to bring it to India. We've been delayed slightly, inevitably, by the COVID pandemic, but we're going to bring it to India in the next year or so once COVID is over. We're going to run a quality improvement forum in India. And it's interesting to look at the quality improvement forum, and it comes down to commitment and change over time. The quality improvement forum started 25 years ago. I wasn't there, but I'm told they had 300 people in a room talking about quality improvement, and all those 300 people had quality improvement in their title, in their job title, all of them. Now, the last time I was at the quality improvement last year was in London, or actually it was in Scotland, it was in Glasgow. And there were quality improvement people there as well, but there were also nurse educators, chief nursing officers, medical directors, clinical directors, heads of department, managers, chief executive officers, foundation year doctors, junior doctors, medical students, nursing students, junior nurses, all of whom felt that quality improvement was part of their job, even if it wasn't in their job title. And that's ultimately what we need to aim for. And it is incredibly heartening when you see that. And it takes time, hopefully not another 25 years to get there, but it does take time. And that's what we want quality improvement to be. We want it to be mainstreamed. We want everybody in healthcare to be thinking quality improvement is part of my job. It's not something that I leave to the quality improvement department that sits in the management block, or something, oh, I need to go to an audit meeting once every couple of months, and that's my work in quality improvement done. That's not what we want to achieve. So here's our quality improvement forum, and we have the best people from quality improvement. We literally have the royalty of quality improvement, people like Don Berwick, but something else. Occasionally we have real royalty that come along to our quality improvement meetings as well. So this is Princess Anne in the UK, who gave a talk, an excellent talk on our quality improvement forum at the BMJ a couple of years ago. And it's an opportunity to meet people and to network and to present your work through a poster, which is a good way when starting off, and to learn and to look at other people's posters and to learn from feedback on your own one. So I always say, when going to a meeting about quality improvement, try and take part, rather than just coming along as a delegate. We also run a meeting called Leaders in Healthcare. And now it comes to favorite bit of my talk. And of course, BMJ is most keen on this, on people who might want to write up their quality improvement project. But I'm going to pause now for the last time and ask you another question. So say you've done your quality improvement project, and it's an exciting phase now. You're going to submit it to a journal, and it's going to land on an editor's desk very soon as you press submit. What do you think is the first thing that an editor looks at in a paper on quality improvement or anything else? And what's the second thing that they looked at? And what's the third thing? So come on, let's put it into your the chat and tell me what you think. What's the first thing that an editor might look at? And the second thing? And the third thing? Okay, so lots of good ideas there. The problem area, the methodology, the relevance, whether it's can be replicated, the process of QI adopted, lots of interesting suggestions. Okay, thank you. Let me go back and share my screen again. Once again, thank you for taking part. It really does make a big difference. So I'll tell you the answer to this question. The first thing, yeah, absolutely, is the title. The second thing is the abstract. And the third thing is the cover letter or letter of introduction. And somebody got that right and mentioned all three things. So the methodology is absolutely important, as is the introduction, as is your results, your discussion, all those things are important. But many papers are screened on title and abstract and cover letter. And so the editor might not get as far as reading your methodology if they don't like the title and the abstract and the cover letter. So it's important to think about these things when writing your paper and submitting it to a journal. But I guess that many of you, by the time you've written your paper and written up your quality improvement project and you're about to submit it, you're kind of exhausted, you're up against a deadline. And then you think, oh no, now I have to write an abstract and it has to be 250 words. And now I have to write a cover letter. Oh, I'll just write, dear editor, please find attached my study. Don't do that. Just spend a couple of minutes thinking about it and trying to sell it a little bit to the editor before you submit it. We'll return to that in a second. So the purpose of writing up a quality improvement project is to share what you've learned, so other people will be able to learn from it. Because too often quality improvement projects start from scratch, and they shouldn't. Often you can learn from what other people have done, but it's important that they share so you can learn from it, and then you in turn share your work. And there's lots of destinations now we can get your quality improvement work published. So there's no excuse in not trying to get it published. There's BMJ Open Quality, what used to be called BMJ Quality Improvement Reports. It's 8 years old now. It publishes mainly quality improvement reports. It's open access, so do have a look. It's all peer reviewed. Have a look at the reports up there. It's heartening to see so many of them are from an interdisciplinary audience where junior teams of nurses, doctors, allied healthcare professionals have written up these reports. That's more about it, but I realize we're running out of time. One important thing is SQUAR guidelines. So to write up your report according to SQUAR guidelines and tell the editor that you've written up the report according to SQUAR guidelines, you're much more likely to get accepted, or at least for your paper to go for peer review. And I won't talk through all of this, but the SQUAR guidelines, they're open access. If you Google SQUAR guidelines, you'll find them, and they're self-explanatory, and you can look at the summary of the SQUAR guidelines here, but you can also drill down and find out exactly what it means by measurement, etc. There's another journal here as well at the end called BMJ Quality and Safety, which is more difficult to get into, to be frank and to be upfront about it. It's easier to get published in BMJ Open Quality. This is more about original research and systematic reviews, and it's slightly more academic journal. But if you can, then so much the better. You're getting into a journal with a higher impact factor and better citation. So that's the end of my slides. I'm very happy to take any questions that any of you might have. both verbally